There it is.
Not sure.
A little more right. Flex. Hey, how you doing, guys? So this is Dr. Sutter at Specific Chiropractic. In this video, we're going to talk about Meniere's disease. So we have a special gentleman. He flew all over from Texas, and you've been dealing with Meniere's disease. Clue to the viewers, how long has that been going on?
Well, I'm 58. It started when I was 19, and then it came for about 7 months in my left ear. And then when I was 22, it came back for about 6 months. But then when I was 27 in 94, it really hit hard, and because I lost like 30 pounds, lost all my hearing, had tremendous vertigo, but it's been lying dormant for 30 years. I felt great, and then about 90 days ago, it came into my right ear. So in the last 90 days, I've had fluid on there. I think about 70 of the last 90 days, about 5 bouts of vertigo, and a lot of ringing.
Okay. All right, so that's what all those key trademark symptoms of Meniere's disease. So here's a story with Meniere's disease, okay? So we have the inner ear over here, okay? And then we have a nerve, the vestibulocochlear nerve, right? Now with Meniere's disease, it's actually like a perfect storm. There's actually numerous problems that need to occur at the same time to make Meniere's disease occur, okay? So we also have the trigeminal nerve. Okay, so why all of these fellows are all important is because when we start to have a dysfunction to the trigeminal nerve, that nerve innervates the soft palate, which is the roof of our mouth. Okay, and in addition to, we also have what's called the eustachian tube. All right, that means there's a little drainage that comes from the ear and goes to the top part of our mouth, and you can see when you lift your mouth, right over here, there's a hole over here, there's a hole over here. So the fluid from the ear is supposed to drain in there. But if the soft palate collapses and puts pressure on the eustachian tube, you can't drain it out, okay? So when it can't drain it out, the fluid builds up in the inner ear and then irritates the cilia in there. That's what causes that vestibulocochlear nerve to go nuts. You get the vertigo, the dizziness, so on and so forth. Now that being said, okay, since you've been deaf in that left ear, okay, for 30 plus years, I'm gonna let you know that considering all my previous patients who have been deaf with Meniere's, okay, most likely I can't help you with that one, okay? We pretty much crossed the point of no return.
Yeah.
However, the right ear, because the fluid started to come back up that one, okay, I believe we could actually save that one.
Okay.
All right? So therefore, what I'm gonna take a closer look at on you during examination is there are key spots. I'm going to see what's going on this region of the spine here. That deals with the trigeminal nerve. And this one over here is to recenter your atlas and everything else to help clear off even more of that eustachian tube and take even more pressure off of the nerve and your brain stem to allow the vertigo or everything else and the symptoms of Meniere's to calm down.
What actually causes the hearing to go away? Is it the fluid on the ear? By the fluid getting on the ear, is that what destroys your hearing?
Okay, that's a great question. So now I'm going to clear this up over here. Okay, so if we call this like the membrane inside the inner ear, okay, we have these cilias over here. Right? Now, when there is air, right, and there's some kind of sound conduction going on, okay, it's supposed to basically move these cilias like this.
Okay.
But if there is fluid, okay, just like us try to move and try to run in a swimming pool, we can't move too fast. These cilias don't move as much.
Okay.
So over time, okay, and you set it chronic for a very long time, we start to lose that nerve function in the cilia.
Okay.
And in essence, they become numb, and then boof, the nerve doesn't work anymore. It does not recognize from the vestibulocochlear nerve. It's like, okay, we're not getting really any data from there, and then eventually we get deaf.
So if you get rid of the fluid, then you really get rid of the problem.
Correct.
Okay.
Okay. So that's what I was saying is before is that because it's like 30 plus years, all that cilia, the damage.
Yeah.
Yeah. Even though I removed the fluid out of there, nope. All the cilia and everything else is just too badly damaged. Right. That's why the prognosis of trying to restore your hearing out of your left ear is not great. But the right ear, you can do something about that.
I'm excited.
All right. As we touched base before, I want to take a look at what's going on with the trigeminal nerve and also what's going on upper cervical region over here.
Okay.
So when I take a look on your lateral X-ray over here, I do see we got some degenerated disc over here, okay, and that fits cervical, that's in trouble over there. So I want to confirm and take a closer look on examination if that truly is the case we need to address. That second cervical over here is very inferior, all right? And also you got an anteriority on that side. So therefore it makes sense for us, because this is rotated towards the right, like this, and also tilting like that, okay? What's gonna happen is the atlas itself is destabilized and pushes itself this way.
Okay.
So by adjusting and recentering your second cervical from here to here, it's gonna re-level the atlas itself and make this atlas, instead of being tilted this way, I wanna try to re-level it this way. And that's what's gonna help take a lot of pressure, because your brainstem is also going right through here. So by tilting it going this way, it's gonna start pinching the front part and the bottom part of the brainstem over there, also contributing more fun stuff for the Meniere's, okay? Now that being said, because it's degenerated over here on the right side and also on the left side over here, okay, then what causes that? Well, in essence, what I'm seeing right now is your spine just did this. Okay, so what caused this? Then I'm gonna trace all the way straight down to the bottom part. So I'm looking all the way straight down. Okay, interesting enough, we got quite a bit of degeneration over here. Keep on tracing on even more. The right hip. Why is the right hip sinking down this way? So what I'm seeing on the X-ray right now is your right hip is sinking this way, going back this way, and slightly going this way. Okay, so in essence, can we go look like that way? That's gonna be tough. Okay, so your body is trying to get to this part over here.
Yeah.
So that's why I'm seeing these little compensations, the twists, going on like this. But over here, it immediately did a counter rotation over here. And then keep on twisting left, right, left, right, left. Keep on going all the way straight up. So, no, I want to take a close look, see what's going on over here. Do we balance things out over there? We may need to address this mid-dorsal over here, that 6th dorsal in the future session. But we'll take a closer look at that fellow over there. And maybe with that side slip on the 2nd dorsal. But that fifth cervical, I also want to take a close look at, same thing with the 2nd cervical. Now we start off with visualization and inspection over here. So the reason why I want to do that is because I want to see what kind of defense mechanism is his body doing. Because clearly if some kind of inflammation is going on, yeah, this is red over here. And see, this should be nice and flat, but this is all swollen on both sides over here. And just lightly touching it, see, this is nice and soft over here, decently, in relation to this. But on the left side, it's very muscle spasm on the left-hand side. Tracing down here, very swollen over here. See, this is also his postural muscles over here, the rectus spinae and the rhomboids, tight over here. Okay, we got a pitting edema right there. Tracing all the way straight down. Okay, we got another pitting edema right here in that 4th lumbar. Pitting edema right over here in the right side joint. Okay, we got some issues going on there. This here as well. Okay, his muscles all tight on the right hand side. It's still tight on the left hand, but not as much in relation to the right. Okay, so we got a reading at this level. Now this device over here serves 2 very important purposes. Number one, it's going to help identify some potential areas we want to take a closer look at during examination. And the other purpose is that on subsequent visits, we want to see that nerve reading going down. So when it goes down enough, that also tells us, hey, we probably want to lay off and don't want to try to adjust it too much. The body needs to heal. So, left hip, moving decently. Right hip, brick wall. Okay, we got something here. Okay, that's not moving too well in that direction. 4th lumbar. 6th dorsal. Actually, this is partially fixated. It tells me this is a compensation that's trying to turn to subluxation over here. Okay, the second dorsal is not moving too well. That's taking a lot of tension from the hip. How's that fella right there, sir?
Yeah.
You're not too fun right there, huh? Yeah, that's a fifth cervical. How's this fella right there?
Not as bad as the other spot.
You see, this is all boggy. It's all filled with a
Right there.
lot of fluid. Yeah, on the right-hand side on that second cervical right here.
Yeah, for sure.
So this is a one heck of a PRS inferiority on that second cervical. Atlas. Decent. Not great, but decent. Okay. The occiput. Yeah, see, it's not moving too well there either. Okay. Right there, like this. No. There it is. Okay. Now, because of this special case over here, usually I would try to adjust only the second cervical alone. But I could tell biomechanically, because we need to see things also fourth dimensionally, by adjusting the second cervical, how is the spine going to unravel itself? And because of that degeneration he has, and also additional with that right hip, the fifth cervical is not going to unravel enough, and it's still going to exacerbate and still going to cause up the veneers to flare really quick. So, but there's an important sequence. As much as I love to address the fifth cervical first, no, it's actually the second cervical we're going to address first, and then we're going to do a very deep correction on the fifth cervical itself. So, this one over here. And also the special line of drive for the second cervical. Okay, we just can't set it this way. I'm going to be aiming much higher up towards this way, because it's so, the bone itself has tilted inferiorward so much this way, so therefore I need to really lift it on this direction over here. Right there. There we go. Luxuration. Right there. There we go. Now we're going to get the fifth.
Well, I definitely felt that move.
Tell us, what's different so far?
Well, I felt it move.
Do you notice any difference in that right ear right now?
Well, my voice sounds a little different. I can typically tell when I have so much fluid because my voice sounds a little strange, so it sounds a little better.
Okay, good, all right. You can relax shoulders even more, sir. A little more, right? By adjusting the fifth cervical in the knee chest table first is to address the posteriority and the inferiority out of that bone, because this is very badly degenerated. Now I'm going to fine tweak it a little more to take even more rotation out of this and recenter your atlas even more. Right there. Right. A little more. There it is. A little more out of it. Good. Okay, sir, walk around, please. Okay, just walk around, sir.
Okay.
Okay, sir. Tell me, what's different?
Well, I definitely felt some stuff move, that's for sure. And I had to move a lot because I really felt it. I think maybe the fullness in my ear, maybe not as full as before.
Okay. How much less would you say right now?
It's like a warm sensation I have right now.
Okay.
So maybe 20% less, maybe.
20% less. All right, fair enough. I kind of expected as such, because you got quite a bit of degenerated nerve on that fifth cervical. Okay, that's dealing with the trigeminal and the eustachian tube and the soft palate. Okay, so now to the viewers itself and also to yourself. Okay, there are three possibilities you may experience in the next 36 to 48 hours. Either you may feel like a waterfall going to the back of your throat.
Okay.
Or B, feels like, there's some kind of trickle, like a postnasal drip going up back your throat. Or C, feel like, I need to cough something. But it's like, there's nothing to cough out, right? So it's gonna be a very tiny, minuscule trickle. So you gotta let me know on the next visit which one of these threes are coming along.
Awesome.
All right? And in the meantime, I start up over here, okay, 20 minutes 3 times a day, and I'll see you next visit.
Okay, thank you.
Well, you're very welcome.
Thank you.
It's been 3 days, so
Yes.
give us the latest updates. How's everything coming along?
Well, when I came in, you could probably tell I couldn't hear much what you were saying from the x-ray, you moving me. It was really challenging. Your tone of your voice was a challenge for me. Sherry's voice was easier to understand. But after we went through the treatment, immediately I could hear you a little better. Not a lot, but a little. And then all of a sudden we were at lunch, and Rhonda my wife was telling me about conversations you had about your wife being a little shorter and the vertically challenged and stuff like that. I didn't hear any of that. But when we went to lunch, I heard a lot better. And when we were walking, when we left, maybe 10 minutes later, just a nasty taste in my mouth. And all day I was swallowing stuff. And I noticed too, I didn't say this when I was here the first time, but sound sensitivity is a serious deal, where banging of stuff, I mean, it covered my ear, and we were at the restaurant and they didn't bother me at all. And obviously I'm in New York City and walking the streets, and it was okay. So I heard a lot better. Later that afternoon, I went to Central Park and walked about 2 miles, and my balance was still slightly off. I just wasn't right balance-wise. But by the end of the day, 24 hours, I mean, my hearing is like perfect. And the unbelievable thing also is my ringing. It took about 24 hours, but I mean, my ears have rang 90 straight days. So the ringing's gone, my balance is fine. We had daughter with her lunch, and she was just like amazed because we helped her move a month ago here. And she just couldn't understand her. So, phenomenal. I'm fired up. Yeah, it's a great report. I mean, my wife's crying while you're in here, emotional. So, great deal.
I'm glad. Out of curiosity, any change with the left ear?
I can't tell. I don't think so. I had a little bit of buzzing in it, but I think that's probably the same.
Okay. No, just out of curiosity, because like I said, as I mentioned before, with the other Meniere's patients I had before, where there was deafness for more than 10 plus years, prognosis not exactly that great there. So I'm still gonna take a look, see what's going on. Okay, let's see what else we could do to fine tweak that a little more. All right.
Yeah, I would wake up at I really didn't wake up while I was having sweat much, but I'd at 3 o'clock in the morning get up and check my hearing. Okay, is this real? I'm okay. So I didn't really pay much attention to my left, just really focused on my right. So I didn't really check my left, so I'm not sure.
Okay. All right, guys, you see how everything's just staying over to the left, over this region? That means there was some core pressure going on there. Slide reading there. So I'm gonna confirm that if the right hip still needs an adjustment or not. But yeah, so you got that core pressure going on all straight down, and it ends right here, the lower dorsals. Let's take a look what's going on here. Yeah. See, he has both readings. So the fifth cervical is all to the left, and the second cervical is just a little bit to the right. It's not too bad. Just pump that up. There it goes. Now it's moving. Okay, so we'll leave that alone. See right there, that 6th dorsal that was partially fixated? There's no fixation here. See, it's moving just fine. So we're gonna leave that alone. Even the 2nd dorsal here, that used to be very fixated in the previous visit, it's partially fixated. So it looks like the whole entire body is untwisting itself, so we'll leave that alone as well. Step back, sir. So you used to have this huge knot there, it's calming down, so I still want you to continue your icing protocol. Get that fifth cervical calmed down even more.
Okay.
See, now we've got something here, that fifth cervical. Second cervical is inferior once again. Okay. So I want to clarify another thing that I forgot to mention about the previous video. So what I noticed is that even though ideally, and that's what Dr. Gunson himself found, was that most of the times the atlas that deals with Meniere's disease, because look at it, it's angled here when normal is supposed to be parallel to the floor. But what I found is that the second cervical, that's why I have to aim in that to really draw my angle down, is because since this bone over here is so inferiorwards, what it does is it forces the atlas to go even more this way, and it's pinching off the brainstem on the back part over here, and also over here as well. So there's 2 points. When it goes through here, it puts pressure like this. So now you got pressure on here and here, okay? And that's what's contributing even more fun part with the Meniere's disease, all right? So therefore, when I really lift it, and when we do a Gunson cervical adjustment, all right, we usually try to adjust it like this over here, sir. Like this, and most of the time it's just going to be set from here and we push it forward. So when we set like this, and you can tell from you guys, our angle is like this, okay? Because we want to reposition the vertebrae back onto the nucleus pulposus, which is a liquid ball bearing in the middle. We want to reposition this way. But just because it's so inferiorwards, that's why when I draw my elbow like this, and when I push it forward, see, it does even a bigger arc. So that's why we really had to move that bone forward to really also to re-level that atlas as well, because that's what I'm feeling over here, and there's the atlas. See, it's only moderate fixation. It's not completely fixated. It's just compensation. That's why we have to address that surface, that second cervical the way it is. And that's why I found the most response for almost 100 Meniere's patients. They actually respond the best and a deeper correction and a much more faster result when we address that inferiority in the second cervical. And it has to be really drop it down like this to really set it that way. There it is. So now there's another thing as well, because the previous one what I did was over here, just the first visit I had to go this direction to really get the posteriority and inferiority out of this way. But now we're gonna lift the more the inferiority by going this direction. Okay, but you gotta relax the shoulders. The key is to make a nice deep set. Gotta relax the belly, gotta relax the shoulders, and then I wanna feel the tension relax right at that fifth cervical. So we just set it nice and deep, and what I'm gonna do is I'm also not only just pushing this way, I'm also gonna scoop it this way to really lift that inferiority out of there. Relax, like that. Now there is a trade-off when we correct cervicals in the knee chest, is that it doesn't address the lateral flexion too well. So you may need to do that angle, but right now on him it's decent, and we're gonna leave it alone, and we're coming up, sir. And because today's your last visit here in the city, that's why we're not gonna go too crazy on it. If you're more a local area over here,
yeah,
I go a lot more in depth on that one, because it's gonna need very fine precision to really re-level and recenter all the bones in the neck, because that's what I'm seeing here. As we see over here, things tilted this way, and your atlas and your head tilted that direction over here. So that's why it's going to take some finesse and everything else. We're going to rebuild each level along the way, because your 6 is also inferiorwards as well. But that's why I have to adjust your 5. So it's pretty much knocking out 2 birds, 1 stone. But eventually, the 6th cervical needs to be addressed. Okay. And then when this finally gets deep and more corrected enough, okay, we have to keep an eye on what's going on the 4 and the 3 over here. Okay. Because in other words, you may, with the Meniere's, it may be like a roller coaster. Okay. Eventually, these 2 fellows, one of them, okay, may show up. But I have a feeling that the 3rd's going to show up a little more. Okay, so that's going to have to keep an eye on from time to time in the future, because that's what I'm seeing over here. It's tilted a little bit this way. So as we start to stabilize and level everything up like this, number 3, it's not going to follow along. So as we start settling on, it's going to go like this and still wedge open like this way, or wedge even more. Okay, so don't be surprised. You may start to experience this. Hey, wait a second, what's going on? Since a wedge over here, it's going to pinch off the nerve to the right, and you start getting that fluid fill up, and then meniscus start relapsing a bit. Okay, so just something to keep in mind. Okay, so there's no panic. You know, we're on it, and you know, I'm going to give you all the notes with my buddy over there. You know, keep an eye on it, and also on top of that, we have this swollen disc right there. That's something we got to keep an eye on as well. All right?
Okay. How often do you think that should be looked at?
I don't know. What we do is this for us guys, the chiropractors, right? We always do a thorough examination every single visit, and I want to keep an eye on, just like a chess grandmaster, every single movement. Every time I do it, okay, I want to see how all the other pieces are moving as well.
Yeah.
Okay? And when it's ready, then we start going upwards to start steadily rebuild the rest of this neck over here.
Okay.
All right.
Awesome.
Okay, that's what the story is going to be. All right. Don't forget, continue icing it, and just like I said before, you know, you felt all that mucus. Yeah, that's some fun stuff. So
Yeah.
make sure you drink a lot of fluids. You're probably going to still have a little more drainage, and you may have some more drainage out of this one as well. So
So today, when the adjustment, was that more on do you think that will help my left ear for the adjustment today?
possible.
Yeah.
I don't know.
Yeah.
I would definitely like to hear more about it.
Yeah.
You know, in the follow-ups.
Okay.
All right, sir.
Awesome.
All right. Have a safe trip back to
All
Texas.
right. Thank
All
you
right?
very much. Thank
Oh,
you.
you're welcome.
Yeah, so I think one of the things too, talking to several doctors, you know, 30 years since I had this, and people were like, there's really been not a lot of progress. And, you know, they told me take diuretic, low sodium diet, and I've really been researching to try to find somebody that could help us. And then I watch your video on Meniere's, but I watch a lot of other videos you had too, and just saw the success rate you had with people. And so I called on Monday and talked to one of you ladies, and then next thing you know, Dr. Sue got on the phone and shared with me about the process and the confidence that he gave. He said, let's get you in so we can nip this in the butt. And I have it on because I have InnoCaption, I read everything what somebody says. So that statement, I think I read all week long, over and over and over, just for confidence. So I appreciate you guys getting me in within 4 days and then seeing me a week ago, not even a week ago today, I called because I was really suffering and challenged, and what a difference a week has made. So appreciate everybody at the staff. Thank you guys.